So Shailee, as principal of Lumina Health Partners, where she works with ACOs, health systems, and integrated health networks, and you may have heard of them before. They've been published several times in HFMA magazine, so we're really excited that she could be here and join us today.
Everybody. Shailee Chopra. I'm the Chief Digital. We, Lumina Health Partners, are a small boutique consulting firm. That's what we like to call ourselves. We're based out of Chicago with our consultants and teams spread all over US. We're a group of folks who are recovering healthcare operational leaders. Myself, I've spent 20 years in healthcare. It's primarily dealing with technology, and that's where I got all of it. Consulting now for about 10 years. My out of other large healthcare organizations across the country, serving roles such as chief medical officers, chief clinical officers, having the road marks with all the failures and learnings that we've had, and really at that want to leverage our experience in service to other organizations who are navigating, play small balls, for big value. That's kind of our core philosophy as well. Even though our core founding members have been in consulting for over 15 years, and we went through, this is our third venture together. In here, the last two ventures we got bought over by other big firms. So we went through that phase of build a consulting firm, make it big, make a lot of profit, get bought over. And then we've come a full circle to we're just at that point we want to do selective projects. We really want to position ourselves as trusted advisors of healthcare organizations and create value. So a little bit about our Lumina company. Well, leave it to the techie to not know how to figure out a clicker. There we go. As I mentioned, we're a small advisory firm based out of Chicago. We work with large healthcare organizations, clinically integrated networks, ACOs, large provider networks across the country, helping them build their strategies in transitioning from volume-based to value-based care. We work with organizations in 4 key areas, helping develop the strategy of CIN formation, ACO formation, entering into value-based contract, how to get ready to get into a contract. If you're in contract, how to set up operations so you can really optimize the value and return. The contracts, digital innovation and analytics, which is really the service line I lead. We work with organizations in selection of the appropriate technologies that will activate that strategy, because we're really big to strategy without activation is just a really good looking plan on a piece of paper. How do you take it from a vision to a reality, and what do you really need of it? Data governance. Data means nothing until we know what to do with it, what actions to do with data. That's where our philosophy on data governance comes into place. And then we do a lot of work on advanced analytics. And that's one of the area I'll share with you some of the work we're doing in terms of analytics in understanding the value being created out of the population health programs. I was recently talking to a CFO from a large healthcare organization, and we were just having chat over a glass of wine, and he said, this is like a big black hole, population health. You keep pouring in money, you keep buying technology, you keep bringing resources, you keep pouring in more and more money, yet it's just completely nebulous on what value we're really creating out of it. It seems we're doing the right thing because it seems like the right thing to do. It really is not much of a choice given the change the industry is going through. But when do I realize, and at what do I realize the ROI from all the investments I continue to make in population health programs? And the models on analytics that I'll share with you that we've been developing are some of the ways we help organizations understand where ROI is being generated, at what pace, and where it really is not being generated, even though it's the good thing to do. So that's the type of work we do. One comment I do want to make is we are agnostic. Sell any platform. We do not sell or any technology or operational vendors. Given our experience, we work with the whole gamut of technology vendors that are ours, to large of digital health, digital innovation vendors, which is what I deal with. We don't endorse a platform. We work with organizations with what you already invested in technology and operations. So we meet you where you are and really architects of bridges between the vision and the reality. You know, you want to get on this journey of value-based care. Made all these investments, yet there are all these disjointed parts that really are not coming together to build a cohesive story. Not a cohesive story for a healthcare operator who's trying to understand, am I doing good? Am I doing good enough? Am I in trouble? At what rate am I going to realize the value? For a provider who is mostly burnt out with the influx of technology and thou shalt do this and this and this, and really just trying to get back to, I just want to take care of the patient, meet the demands of this new ways of providing care while still keeping a baseline of quality of care I want to provide. And really from a patient perspective as well. Am I getting the right experience I deserve to get? And I would rather take it a step further from a consumer perspective. Do I have a choice? I want to exercise my choice in picking the provider or the experience I want to get in healthcare. So how do we really bring it all together? That's the work we do for organizations as a trusted partners. Our two other service line on clinical transformation, we work on optimization of service lines, of taking them further in developing the clinical programs and developing the operational workflows around the clinical programs, be it oncology, be it other specialty programs, and tying it with the data, tying it with the technology, and bringing it back to what the payers or the contracts are demanding in terms of output. So doing what we need to do, but always being able to tie it back to what needs to be done and what outcomes need to be achieved. And lastly, our latest service line on Lumina Leadership Institute, which we're very excited to launch, it deals with educating the providers. In this new day and age of value-based care, it is more and to learn how to track data, manage things. No offense to physicians in the room, but maybe not the best collaborative people managers. Yet they are put in positions where they are not only leading programs, they're leading people. So how do we support them and equip them in really learning the operational leadership so they can be successful leaders? And that's the part of our Lumina Leadership Institute. One last comment about me. As I mentioned, my entire career has been on data and technology. I really am the data and techie nerd of the group, and I wear my nerd badge very proud. But my big passion in having spent over 20 years in technology field is true success of technology was the technology operations for a large healthcare system in Austin, Texas, which is where I'm in hospitals, about 2,500 providers. And I even went through, I was smiling when Susan was talking about the collaborative that you guys have successfully implemented in Oregon. We tried to do the same thing in Central Texas about 10 years ago. And as the leader of interoperability for the region, I was damn proud of myself when I implemented the first health information exchange in Central Texas that was exchanging information between the 4 large healthcare systems and the providers, none of whom information of the patient who ended up in any one of the healthcare system. We had alerts, the technology was beautiful, we had all this data flowing in, but it failed. It failed not only for people of the community, it failed for me personally. My father was visiting me at that time from Delhi, and we used the same technologies that I had spent 10 years implementing. So there I was waiting for it to work and show, yes, this thing works. But all of it, besides all the data, it was not telling the story of the patient. And it was also not prompting the providers to take a step back and truly look at the holistic story of the patient and use critical thinking, critical clinical thinking to take a step back and go, 61-year-old male, shingles, not unusual, but constantly losing weight in 4 weeks, Why is there such an extreme reaction? And what each one of those four healthcare systems decide, despite massive amounts of data being sent about my father, despite $80,000 in the bills that we racked up in the 4 weeks, they missed that behind on technology, data does not mean better. Make it about better care and better outcomes. Data has to drive actions. Data has to be converted into actionable information. And then more importantly, it has to be positioned as consumable knowledge. It has to be deeply intertwined with the clinical and the operational workflows. So it's not a static report we look at. It really just drives the next question that must be asked. Governance. Unless we handle the cultural change, unless we handle the trust of data, the trust of technology, so you're not questioning the data, but you're really believing it and taking the next action, we've really not moved the needle. And those are some of the founding principles of our advisory services as we work with organizations who have invested massive amount of dollars or are at the threshold of making those investments in population health programs. In how are you utilizing all of your investments you've made and truly move the needle? Do you know when you're moving the needle and when you're not moving the needle? Better clinical outcomes just in its own doesn't mean success. Better clinical outcomes at reduced cost, at a satisfactory experience. Yes. So what is that story and what does it take to, what does that infrastructure of operational workflows, of technology workflows, of data workflows, what does that look like to truly move the needle is the heart of the work that we do at Lumina that certainly I've invested myself in. So enough about me and Lumina Health Partners. Where we are in the healthcare, I know that sounds very cliche, the only thing constant right now in healthcare is change, but it's also true. Times are very interesting, they're unsettling, but I also believe they're very innovative times. Two conflicting care paradigms. The fee for volume that we've existed in for a long time. Fee for volume, the key element of success is higher profit margin. That's how we've been operating in. Get more people in, you treat more, you have more margin, and that's how our CFOs or the financial leaders have measured success. And now we're moving into fee for value by choice, and sometimes not by choice. We just are moving in that direction where payments are used to incentivize reduction of cost coupled with improvement of quality of care. While we inherently targeted improvement, never cared about quality, we did. Now it is what drives our payments. So we need a different type of data infrastructure to really measure how are we improving the outcomes, at what rate, and then at what cost, and layer in the last perspective, what kind of experience are we creating for our patients as well as our providers on that. So that really shifts the paradigm a little bit. And there's an inherent conflict in there too, that as we get into fee for value, we're shifting volume away from our EDs. We're shifting volume away from our hospitals, even in some cases, and moving into primary care, moving into tertiary care settings. So really from a financial perspective, there has to be that balance between what we're taking out, we're putting it in other channels, investments we're getting, and what are we losing in terms of volume. So balance forms the foundation of the data infrastructure. Some of the trends we are observing in this new world is that commercial reimbursement for service is plateauing or decreasing. For example, for primary care providers, it's been our observation that the reimbursement has really flattened out or maybe slightly increasing 2 to 3% in the last couple of years. For specialists, however, we're noticing that it is decreasing from about 5 to 10%. So specialists, as we work with them, they're sitting back and going, how do I restructure my services? How do I creatively partner with other healthcare organizations or ACOs or CINs so the reimbursement structure stabilizes and gets on the trajectory to increase go forward? Because if I stay with as is, it's going to continue to decrease there. Providers who are taking happily or happily steps towards preparing for risk succeed in this new world on there. Need of Medicare and wanting the providers to take continued the pressure on the providers to really prepare themselves and their operations to take the risk. Providers continue to provide incentives for utilization management. Providers can come back with the data of here, I have done these programs, here are my clinical outcomes, here's a proof I can show you that I'm reducing the cost, and now let's get to the table and let's talk about negotiating differently. And finally, the whole industry is also shifting towards what does it take to be ready for risk, and what are the steps to be taken for that. As we think about value-based, 5 key drivers of success that position organizations to be successful under value-based contract. Scale and demographic reach, the ability to outreach, to have a footprint, the ability to expand the footprint in current market or new markets amongst a different mix of specialties. So how they manage their network, not only the performance of the specialties of the services that are being provided in the network amongst various service lines, amongst various venues of care, be it acute, post insurance plan for the employed population or incentivizing healthy behaviors. You know, I, for one, our health insurance is through IBM. My husband works for them. And, you know, we have this plan of if you're doing 10,000 steps every day and working out, do log into your app, and then you get 10% off your premium. Something that we strive anyways, but you know, it's a great way to just incentivize and keep track of what's really getting into the rising risk and high risk. That's where we get into using care intervention for early diagnosis of those complex conditions of comorbidities. Because earlier you're diagnosed, earlier you can have the intervention and prevent the patient from getting into perhaps the high risk, which is where that is most costly to the healthcare system. Yet we have realistically a lower degree of impact to really change the health of the patient, because we're really at that point in a reactive mode to really manage the health of the patient. And then that's where, from data perspective, a lot of looking into some amount of predictive models to say, based on my historical performance, this is what I anticipate my performance could look like in the next 1 year. But it still assumes I'll still continue to do business as usual. So you still get some sense of where you can be, but you don't have the controls or the levers to do the strategic planning on what if I change these cost levers, or what if I change these programs, what impact does it have? But yet that's really where our industry is right now. As we shift our focus from just working with high-risk populations to the rising risk populations, there is more technology available out there that does maybe some more advanced predictive modeling. And most larger EMRs, Epic and Cerner and all, definitely have that within them, where you can start population health of different cohorts by different disease conditions could look like, so you can plan for where to make an investment. But really the missing link right now, at least from healthcare operational leadership data, clinical data, the claims data, and whatever little we have in terms of social determinants, what am I going to get out of the investment I'm making? And at what rate do I need to be putting in money? Do I still go ahead next year with the 20 case managers that are managing these and transitions of care? Is that still the best way I'm going to get the maximum output out of my value-based contract? If I put in 5 more case managers, does that mean I'm going to get more ROI? The answer is probably no, because it depends on the program. Because it could be that a certain program, a certain population has just reached its plateaued in the ROI it's creating. So it's not a matter of putting more bodies. It's a matter of picking the right program where you can get the best ROI. The financial data, which is the investment you're making in running these programs, really limits your ability to come up with a tangible ROI, because you're just predicting based on the previous performance, this is what my future performance would look like. There are a few vendors out there that have started to dabble in the space of advanced analytics, and usually the common term that's used is value modeling or ROI analysis that has started to come out, but it's not very readily understood. And I think that's where the gap comes in, is technology vendors. Traditionally, when technology is implemented, seminar, goes to a webinar, sees this technology, looks at the pretty screens and go, that's exactly what I need. It goes through the contract process. The vendor is approved, vendor comes in, all good intentions, the technology. Now you have this beautiful piece of technology that can potentially produce the areas where we help close that gap. As I mentioned, we're vendor agnostic, so we do not work on selling a platform, but we can help close that gap between what you have and what those ROI analysis could look like. Oh, I had animation on this slide. Okay. So really, and I think you've probably heard the passion about data in my voice thus far. The basis of success in the value-based contract is data. And for a data nerd like me, it really is music to my ears, though I realize I'm probably one of the few who gets really excited about data. Everybody else means that, can you just give me the report? And that'll make me happy. Yet it's not easy. because there are nuances of the data that is available that we realistically, where rubber meets the road, have access to. For example, payers. I mean, we're going to get from the payers at the pace we get it, in the format we get it. And then we have to reverse engineer it for the most part. That's just the reality of there. The reality is, even though all our EMR vendors claim that they support interoperability, that there are no big walls and that they will interact with any other vendor, the truth is they don't. Everybody is protective of their proprietary, and yes, you can get a lot of reports if you just get on that one platform. That's a reality of the data market. It is also a challenge. You, as a healthcare organization or a CIN, you have more ability to tap into data for your partners who are within your network. But as part of value-based contract, you would be collaborating with a lot of organizations who are outside your network. And it's a challenge to get data from them in the format you need. So what we're finding is, as we work with healthcare organizations who are in the early stages of either contract negotiations or defining the contract, there's an opportunity there to include the specificity of the format, the frequency, or the type of data that would be needed as part of the contract. I recognize not everybody is there. But that's one, because we're finding that now that there is a better understanding of what does it really take to manage through a value-based contract, let's go back and include that information in the contract. It's not about getting all the data, about getting the right type of data needed for analysis. And there are two big categories of data: the retrospective data that we get from the payers, that we get possibly from our claims files, from EMRs, that gives us a retrospective look. And I don't want to minimize the value of that. That's a great place to start, and that's where most organizations start. But more and more, the trends are moving to the transactional data type, the proactive data, close to real time. It's probably not real time right now, close to real time data. And it's not limited just to the EMRs, just to the ancillary systems such as pharmacies, just to the community resources like HIEs, social determinants of data. More and more, we're pulling in data from digital health that are coming in. Most organizations have implemented some kind of app for access, scheduling app, interacting with the patients, pulling in all of that data as best to real time, create that data lake. That's going to be the foundation. That ends up being sort of the foundational step of how to measure performance in the value-based contract world. And it really comes down to building a roadmap to mature your analytic capabilities. It's not a linear path. You don't always have to start with retrospective, then move to some predictive modeling, then move to high analytics. As an organization, in your journey to value-based care, and what questions that really need to be answered. That's one of the common myths we hear is, well, we're dealing with claims file, I guess we should need to next go to the clinical data, and then we'll worry about the advanced analytics later. How much longer can you wait, and how much more money can you pour in until question, should I really be pouring in this money, and what value am I getting? Am I actually realistically, do I have a shot at being successful at value-based contract that I'm entering into with the network mix I have? Or am I just entering into that because that's just the right thing to do? Those questions need to be answered early on, and there is ways we can address those questions while you're building the analytic maturity of your organization. I won't read through this very busy slide. But, and you have this slide deck to download should you want to. But essentially, it talks about some of the key points I've already highlighted. It's sort of that methodical journey in laying the infrastructure. Understand what you're going to be measured against in the value-based contract world. Work backwards from there. What is the population you can go after? What is a network mix you have to really support that population? Let's not jump into case management just intuitively. Let's figure out, where are the case management resources best allocated for maximum ROI? There's a lot of redesigning of the care processes that needs to occur in the value-based world, which often gets overlooked, and that's an expensive process. So planning for that early on, planning for data and technology, which often ends up being the unpleasant surprise, but it is always there, planning for that early on, and then evaluating the potential of each investment. Another key common question that we come across organizations that are going in the value-based journey is traditionally all the data work was done by IT in our hospital organization. And now that we're turning into a CIN, or now that we're turning into a collaborative who's entering into value-based contract, who owns the data? And who owns the technology? And what about all these provider offices and specialist offices who are on million other EMR? Maybe not everybody is on Epic. Maybe not everybody is on Cerner. And they have their own IT shops. So how do we really handle this new concept of data organization in a CIN? Do they bring in the data together? Our belief is that probably the answer lies in a hybrid model. It is not about consolidating it all or decentralizing it all. It's really being more intentional on what makes consolidate and what really makes business sense to leave decentralized in different operational areas. And this is just an example of a hybrid model that we've helped implement for healthcare organizations, because you're going to be pulling in data from multiple sources, aggregating that, cleaning it, so that when you are producing the reports, you're not questioning this data is incorrect. It just decentralize actual usage of data. Let's not create a bottleneck that it's only this one organization that creates all the reports. You can have subject matter experts in key operational areas who are trained to use this data and develop multiple operational reports. And we find that that type of hybrid approach is usually not only more palatable, but is also more effective in this journey of maturity of analytics in the organizations. And governance is a key aspect of that. And surprisingly, the key area to lead the data analytics organization is not the CIO, it's not the chief medical officer, usually coming from the financial leadership, because they have an important stake in their, I'm putting in all this money, what's going to come out of it, which is not what you usually hear. Usually CIO who gets put at the table, what are we really trying to do with the data? And who needs to do what with the data? I don't define that, I produce the data. So we normally see a dyad or a triad structure up at the top with the CMO, the chief medical officer, leading the clinical operations, the financial leadership leading the investment, and maybe supported by the IT leadership supporting the build of the data. And it's really where the organization is, and it can be tapered to. So really starting with setting up that governance, which is imperative, I think, morning, developing the trust and collaboration. When I did this 10 years ago, despite best of the technology, it failed because there was no trust amongst the organization. Everywhere the patient went, despite you getting the alerts on, here was the MRI and these are the results, guess what? They did their own MRIs. And it can start with just reporting and visualization and eventually move into the maturity cycle of where you're really understanding the data, validating the data, and you move the needle from questioning the data to really focusing on who needs to do what with this data. And then after some, whoever needs to do whatever with that data, did we actually get an outcome of it, or is it just in the piles and piles of report that we just, that is, this next slide here talks about sort of this problem-backed approach that we're very passionate about when it comes to technology and data. In the example I was using earlier, somebody goes to a conference, typically the first to value-based care, I need an analytics platform. There are tons of them out there, a lot of time and effort gets put in, and vendor, and you implement it, and now at square one. What do I do with it? We strongly recommend organizations consider this problem-backed approach, which starts with what do those programs mean, and how are you going to measure performance under those programs. What part of those performance measures are required by the payer that this is the data you need to produce versus this is the data you want to know internally to know your performance? Upfront, define the problem statements. We're still not gotten to tools. In fact, most of the times when we get hired to come work with organizations to help select technology, which is where I get involved in, most often than not, we end up through our discussion saying, put a pause on that. Let's not go to the technology right away. Or even though you brought the technology, let's take a pause and define what is it that you want to solve for? What are the questions you want to get answer from? Then let's define what information is needed to really answer those questions. What do those answers need to look like? What's the definition of that? Get then next level, what data is needed to produce that actions. And then lastly, we get into the systems. It's not the step one, it's what, 1, 2, 3, 4, step 5. And once you know what systems, that's when you go into what do you have, what more do you need, or what more are you buying in? And that's when we work with the vendors to say, as you come in, even though every vendor claims they can produce every type of information, never are they really going to work in silo. And if they are, they're really not positioned for success and sustainability in your organization. So how do they need to work within your ecosystem of everything else that exists between your sandbox and sandbox of other organizations to produce that information that's going to do the answer to that question? So really pushing the needle from data to information to insights. And that missing in the implementation today is really what enables having, makes the shift from investing $1.3 million in this new analytics platform, throwing in all these resources to really do the implementation, produce a report, to really shifting it from a technology platform was brought in, but here are the insights we're getting. Those go to the governance, and now you're really making the decision on what should we be doing with it, who needs to do what with it, and are we doing it the right way? So that is at the heart of our recommended approach to bridge the gap between technology and operations. How's everybody doing so far? I'm trying not to nerd out on data, trying to keep it at high level, but if I do, please raise your hand. It won't hurt my feeling. So one of the key another areas that's in the value-based world is not just working on improved quality, improved outcomes, but optimizing the provider performance. That word often gets a negative connotation, and I work with providers and they say, what do you mean I'm not doing good enough? And yes, you can bring me all these reports. I don't trust your data. I know I'm doing the best. You don't understand my patient population is really, really unique. So none of these standards of care coordination apply. I get it. And yes, they are unique. There's no question about it. But the reality of the value-based care world is it has to build a cohesive story. It has to fit into the story. So how do we, instead of making it about your performance needs to be better, which is part of the conversation and sometimes a really valid conversation. Dr. Smith, looking at the data, we see that you often order this particular drug for patients with COPD, and that's 5 times as expensive. But also also the type of conversations we can have with provider leadership and value-based world, which is where the analytics can support, is what are the most effective speed to market care management programs looking at the population cohort that provider or group of providers is serving. It's not about we're going to assign a care manager to your care manager for this market. Let's talk about where this case management resource has the most value. Is it really in transition of care, which is where typically care management starts? When we talk about high-risk resources, is it really just the care management that can truly make a dent when maybe the population we're dealing with has mental health issues, has maybe, they're homeless, they need some housing and food. So really that needs to be a combination of care coordination, social services, maybe combination of some other post-acute care facilities we can bring to the table to help effectuate their their care there. So it's really sitting with the providers, getting them at the table in defining this new ecosystem of care. And that's where you get their buy-in versus here's another way for you to do it, and here are the reports on how through which we're going to measure. A lot of focus also we're seeing coming into how are care management engaging, reaching out, and enrolling the patients. As I mentioned, instinctively we start with transition of cares. Let's throw the care management on a high-risk patient. And they get a spreadsheet, which is probably pulled from 5 EMRs, cleaned up, given to them, put it on a shared drive. They get spreadsheet in the morning and spreadsheet in the evening that they go out and make calls. And while they've made calls, next day they find out, oh, that patient is really not on my list anymore. Because guess what? That patient showed up in ED and there are different comorbidities and the things have changed there. Often making phone calls, recording every phone call in a spreadsheet, that being handed off to the next care manager who picks it from there. Very ineffective. Depending upon the cohort we're going after, I'm not advocating that the solution needs to be that you need to invest in a care management platform, which ends up being sort of the second thing. We need analytics and we need care management platform. The answer lies somewhere in the middle. If we get precise about where we are allocating these resources, then there are ways using your existing technologies that you can come up with work list notification systems that help the care managers document their workflow. So before you make out of your hunch, you can prove these pilots out. You can prove this actually works. You can prove what the ROI is and justify the investment you need to make into that. So consider an approach, crawl, walk, run, that we talked about this morning. We find that that's usually more sustainable and gets more buy-in from the leadership there. Conversation with providers. It's not about that you're not doing good work. It's about which one of the good work yields the most value. Similar conversations even with the case management leadership. It's not about that your 20 case managers are not working 12 hours a day to follow patients. You're really getting the maximum ROI out of the transitions of care program. I was in East Coast working with a large healthcare system, and we're helping them through their value-based care strategy, and with specific focus right now on putting in the infrastructure for case management using analytics and protective of the work they do. And we went in and we did some analysis of here's the contract, and this is the percentage that case management is handling. Here are the outputs. And the data spoke the story that only 4% of the total population that the current case management is involved in yields any positive ROI. The remainder, even though it's good work to do, either following up and making sure there is a follow-up appointment with the PCP or connecting them with social care, while it was a good thing to do, it was not yielding any kind of positive ROI that can be tied back to the world. These are the measures of performance. To continue to invest in transitions of care, knowing that it doesn't yield a big positive ROI, and that's okay. But what we did was shifted the way case management approached transitions of care. So instead of 18 case managers being allocated, it was only 8 supported by systems. So their efficiency improved, and remainder distributed to complex, as well as going towards a care intervention for the rising risk population. So it's not necessarily a matter of all 18 that they're doing case management comes into place, because you've done your due diligence in cleaning and proving the validity of the data. So you can move the conversation from this data is wrong to what do I need to do about it. So that's just an example of that. And finally, also looking at redundancies and inefficiencies. When organizations come together as a CIN, Susan had the same example this morning, and bringing back the analysis, and I'll share some examples on ROI calculator is what we call it. One key point I'll make on here is, while under value-based contract, what path to take? At what pace do we start walking down that path? At what pace do we make investment, and when is it that we're going to realistically start seeing any return on investment? It's really not done in isolation. It's not that hospitals are stopping to work as acute care facilities at fee-for-base model. It's really how do we maintain our business as fee-for-volume, and what's our appetite to start investing in value-based care. It really needs to come from there. At what pace do we start making investments, and how does that balance really exist on there? Really, it's the balance between improving the outcomes so people are out of the EDs, out of the hospitals, perhaps moving that into our PCPs and post-acute facilities, managing the financial stability of the overall organizations while we do that dance. And one of the biggest challenge of the financial leadership, and that's the advanced analytics capabilities that we talk about come in handy in helping with that model. So here's the crux of how we do it. When we talk about advanced analytics, we take a look at data you have in your organization, around your organization, with the tools you have, ROI calculator. I've talked about return on investment. What's the investment? And when I say investment, it's the resources, it's probably the physical assets. You know, we have to open a new urgent care to really capture this market share in this area. What are the physical tools required to sustain, to grow, or to start a new program? And what is the organizational impact of doing that? Financial data, the clinical data to do that kind of modeling. We also have, sometimes the questions are really around, you know, as I was talking about the example below, do I really need 15 more case managers in my geriatric program because I'm expecting this influx of patients in that, you know, as we look at this partnership, utilization analyzer, you know, what does the cohort look like? Do we really need more case managers, or is that a different mix that we really need different programs, different layers of programs and different layer of resources? That can be a combination of clinical resources, case manager, and social management resources. And then finally, the sweet spot, which is a step to get there, which is the predictive modeler. So if we were to questions such as, we're in this market and we're looking at possibly, you know, merging with this other organization or collaborating with them as part of CIN, what would our base look like? What could our impact to bottom line look like? What could be our predictive performance if we got into an MSSP contract or this commercial contract? At what point can we hit a positive ROI? You know, is it 12 months, 18 months down the road? Or what are the different cost and levers that we really have to play with to structure what this new CIN would look like? Rather than answering those questions based on intuition or based on retrospective data, we use the predictive modeling to really help come up with answers to those questions that are very data-based on that. This gets into a little bit of technical details, and I won't, but the only point I would make is it's really the key point of value modeling is not to understand the trends, but really take it a step further and talk about why are those trends happening. If there is increase in the spend on diabetic population care, then let's understand what's behind that increase. Do we have a shift, employers showing up in the market that are offering new services that this population is able to afford, and therefore it's impacting that's behind those trends, that's impacting the financial outcomes, and that's at the heart of the ROI calculator. So really, it approaches it from economic perspective, the financial. So, you know, putting a CFO hat on, what do I need to cut the check for, and what is it for, and how would I know it yielded any value? What does that value look for? But then also looking at the cost of care component on the side, balancing it out with, are we really improving the outcomes? Are we reducing the cost? And are we reducing it at a pace that we're not destabilizing our current fee-for-value infrastructure, because it's not going away. We're pretty much having one feet in, you know, two boats, if that's the right analogy. We're going to continue being in the fee-for-volume world while we build the fee-for-value. And what does that balance look like? Lastly, and I think we've talked about this a little bit, reductions in the medical spend are a byproduct of reductions in the avoidable utilization, the bad utilization. So ED, coming to that, there's a lot of effort on avoidable EDs. That's not a new. Inpatient acute visits, inpatient subacute, you know, we talked about avoidance of certain elective procedures to reduce the cost. So that certainly has a positive impact on the ROI, but it's not just reducing the bad utilization, which is where organizations have a lot of focus on. In parallel, there needs to be programs that improve the good utilization, which is office visits, the skilled nursing facilities, the home health, have programs allocated to that. So as you increase the good utilization and decrease the bad utilization, you get an optimal ROI in the value-based world. So in short, I think I come back to that same cliche I started with. Where we are in healthcare, change is the only constant. It's true. But as the changes are happening in healthcare system and we're bending the curve, it's making us all accountable. It's making us accountable at the operational perspective, but also the provider or the clinical care perspective. And really, I would take it a step further at a patient and a consumer perspective as well. In a lot of ways, the agreements I get in with my provider, with my employer, hold me accountable on the decisions I'm making on my health as well. So it's really accountability at all three levels. The new financial models that are coming up in value-based world are not only going to align the incentives for organizations, for providers to take on risk, but I think it's also going to modify behaviors. It's going to modify behaviors at the provider and clinic level, at the patient level, and ultimately at the organization level as well. And I could not emphasize enough the importance of cultural change, the importance of integrating operational workflows with technology and data to really make it meaningful. Otherwise, it's just another stack of pretty looking reports you can get out of after spending millions of dollars in it. So the journey is complex. The journey is interesting. And we certainly enjoy being part of the journey and developing partnerships with healthcare organizations and being their trusted partners in navigating this path. So that's it. Any questions for me? And I hope I didn't go too deep into the data.
I have a question that is associated but not totally on the analytics area. So I'm not sure. When it comes to AI and blockchain, how ready for prime time do you feel that is and its alignment with analytics?
Oh, I'm so glad you asked. Are we ready for prime time? No. My personal opinion, we are a few steps from there, but have we moved from it being just a fancy technology or dream on the paper, and are we invested in doing pilots? I think we're definitely there. In my mind, AI and blockchain is where 10 years ago, when I was leading the interoperability for Central Texas, and I saw my first HIE demo, I was very arrogant in saying, why do I need an HIE? I have a health interface, 100 interfaces. Boy, did I eat my words or not. Similarly, conversations a lot of time I have with providers. In fact, last month, I was having conversation with a chief medical officer, and we were talking about telemedicine. And they rely quite a bit on telemedicine programs too. And we were talking about, it's great. Telemedicine helps provide access, reduces the cost of care. Imagine how we incrementally shift the value we create out of telemedicine if we leverage AI and the clinical decision support system in triaging the patients that really should be routed to this specialist or not. And we went through some scenarios. We talked about it that, looking at this patient, and they're piloting with Watson on that. If we triage it, we saw we were 15% of patients that we were routing to that specialist that should not be routed there, in fact, can be taken care of in an alternative way. So right off the bat, they were tangible ROIs. Not to mention, it makes a specialist so much happier. So because he's not going to be waking up at 10:30 at night on a Sunday night to take a look at the patient only to realize to say, you know what, no, what you need to do is go back and get another MRI done, or you really need to see this doctor there. So there are definitely a lot of use cases. Being passionate about digital innovation and digital health, we do a lot of work with companies across the nation. So are we ready for prime time? No, not at all. I think it's a reality, and we're moving in that direction. The question?
The example that you gave with the case manager on the East Coast, that was really interesting. Can you provide another example where you implemented a data-driven policy or action item at another organization?
Okay. So I'll pick another example from the East Coast client again, and their ears must be burning today. When we started looking at the data, they had transitioned to, they had just had a large Cerner implementation, and like many other implementations, when you do an EMR implementation, you have to expect a rocky period before you stabilize. And while they were going, providers being very upset and patients being very upset, well, they were losing data revenue. So we went in and we did analysis in the background on, it was really not system issue, it's how the programs are designed. They were really not leveraging the systems on there. In other words, typically EMRs are designed to document episodes of care. You know, patient shows up or patient shows up in ICU or med-surg unit. Yet when you are looking at value-based care, you're transitioning the care and how they're going on, then not all of it was captured in the way the EMR was designed. So simply services were being provided that were really not being documented and therefore being billed anywhere on that. It's just another example of using database there, database approach on there. So it shifted the focus from EMR sucks to we never build the bridge between our reality and what we're going to use the technology for. And that was really the missing link, and that was really, EMR came in and it was built. It worked well for your within one set of brick and mortar, but the reality of healthcare is we don't work that way. We're really across the continuum. And EMR, not only the EMR vendors or technology vendors are catching up, the healthcare operations are catching up with that and defining what their reality looks like. Did I answer your question?
Absolutely.
Thanks. Your presentation touched on something that in other presentations like this, I've seen missed, and that's cleaning of the data.
Yes.
And I mean, because otherwise it's just like garbage in, garbage out.
Oh, absolutely.
In these analytics systems, and it just makes like bad things happen faster. Or in your utilization case, that physician will find errors, and the credibility of that tool is just gone.
It's gone.
So,
you have one chance at credibility.
Right. And like historically, that cleansing process has been very labor intensive, measured in months and everything to get it to where it's trusted. But then you also talked about that using those real-time analytics or near real-time. So what strategies have you all seen to get that data to where it's trustworthy, but also relevant, and that process doesn't take months? It's actually just coming in and you're confident that the water you're drinking is not going to kill you.
Absolutely. So painful. Nobody likes it. People doing it don't like it. People who have to pay for those people doing it don't like it. It found works better is, even though it takes months, let's really break it into sizable bites on there. So we take, so we form governance. We talk about we're not going to solve it all. Not all the data can be clean. Let's pick 5 problems we're going to solve first. So for example, we picked for these top 10 utilization provider network, that had 4 cardiologists, 2 1 family care doctor, their performance reporting. So we picked 1, performance reporting. We picked the other area as how we define the patient, because one of the typical questions we would get from the providers, or these are not my right patients. We can't solve it all. Clinical data behind what are, how did we attribute the risk or that and validate it for us. And then it goes to those leadership experts. So they are invested in the process of data cleansing and understanding that. But the benefit of that was, even though our overall plan is a 12-month plan, we started to build our credibility through these bite-sized pieces we would take on, have learnings from it, have successes from it. So then these 5 providers, 3 of them were the most vocal against the data thing, really started to become our advocate. I mean, they shifted from saying, I hate data, these guys don't know what they're doing, to, all right, they have a method to the madness. You know, I'm seeing what it's working on, to then slowly becoming our advocate. So my biggest sort of agile methodology is something that healthcare, I know 20 years in healthcare, I did not embrace that because we're very conservative and we're very regimented. But the reality is more and more, you know, we really take the same principles of that and apply it to that. Did I answer the question? I appreciate this opportunity.